you have a patient who has done well on Tagrisso for 22 months. And at that point, they have one new lesion in the lung. At that point, I think many of us would favor radiation just to that spot and continuing the treatment. Yes, I don't think that's even much of a controversy. We don't have a lot of evidence on that, but we generally feel that if it's what we would now call oligoprogression, oligo meaning few, so one or two isolated areas, but the background well controlled, there is limited but very consistent evidence that if you treat that spot, you can have patients continue to do well on ongoing systemic treatment, the same Tagrisso for months to a year or longer after that. So,
cancer begets cancer.
Right. Now, brain, we would say, I think the same thing. If you had one or two brain metastases, what do you do now if there are multiple spots in the brain progressing, but nothing outside of the brain? Is there, do you favor whole brain radiation or multiple sites treated and continue the Tagrisso there?
So that's definitely a more challenging scenario. And I think a lot of that takes into account patient-specific features as well. Some of the things that I have discussed with patients in that scenario are, of course, the risk-benefit of the radiation. But there is also another strategy, which is doubling the dose of the Tagrisso. And it has been demonstrated as well that that can bolster the response in the brain, and then monitoring closely to see if you can get enough of a reduction so that instead of something as drastic as whole brain radiation, you might be able to dial it back and just do gamma knife to some areas. And then there is also, on top of that, considering the addition of pemetrexed, which does have some CNS activity.
Well, let me try to refine it a little bit. You have a patient who you are worried about progression in the brain, but they need to change treatment because of systemic progression. They have 5 new areas of disease, but they've had brain metastases, or there's some ambiguous findings that you're worried are meningeal. Heather, you mentioned that your institution, Dr. Neal has generated some data on the combination of chemo and Tagrisso, osimertinib. How likely are you to continue Tagrisso both to treat potentially still EGFR sensitive disease and to cover the brain while adding something to do better or treat differently in the body?
So I'm going to answer both of the questions. So I think in the first scenario where you've got control everywhere except the brain, then we would oftentimes go with the targeted radiation. So CyberKnife or Trilogy or any sort of stereotactic radiation, right? There are a lot of different brands of that.
So just to clarify, that's a focused radiation.
Focused radiation to the spots and not whole brain. I try to postpone that as long as possible.
Okay.
But I will also think about increasing the dose in that setting. And I've gone up to 160 milligrams of osimertinib. People tolerate it actually pretty well. And there's data from the Bloom trial, which you were alluding to as well. So if someone's otherwise has disease controlled and it's only the brain, we'll try to focus the radiation and then maybe increase dose to try to maintain that control as long as possible. And the other scenario where the patient, if they're clearly progressing everywhere, brain and rest of body, I'm going to think more about switching to a chemotherapy-based approach. Pemetrexed, agreed, has activity in the brain. Bevacizumab has activity in the brain. And so sometimes if we do a complete switch, we'll do that. But then there'll be other cases where brain's controlled on the 80 milligrams of the osimertinib Tagrisso, rest of body isn't. That is the scenario where we'll add the chemo to the 80 milligram osimertinib.